A 68-year-old male, Mr. P, who was a farmer by occupation, hailing from Nizamabad. He studied up to first class. History given by himself and his son. His attitude towards the
Studied
deceased.
only in the first class.
Up till first.
Studied up to
Till
first.
up to first.
He is able to read and write. Read and write. Okay. Up to that level he studied.
Okay.
Attitude towards the deceased is poor. He is a known
Naturally.
case of hypertension from the last 5 years on irregular medications. His hypertension was controlled by one medication, but he's been taking it irregularly. So my chief complaints, he presented to the hospital with the complaints of pedal edema from 1 month, history of decreased urine output from 3 days, and shortness of breath from 1 day. History of presenting illness, I would like to date my history back to 3 years ago when he developed.
So related only you take back your history, because everybody is taking back their histories, but something are related, something are not related. If it is related only, take it back.
Yes, sir.
Is it related?
Yes, sir. History 3 years ago when he noticed swelling in his legs, which was insidious in onset and gradually progressive over 1 month duration. And he had shortness of breath on exertion, that is MMRC grade 2. He was taken to the physician where he was told to be leaking protein in the urine, and he was managed medically and asked to follow up after 1 month.
Possibly.
He took the medications for 1 month. After that, his symptoms resolved, and he did not go for the follow-up. His second presentation was in January 2023, when he presented with the history of pedal.
For the next 2 years, 2.5 years, asymptomatic.
Asymptomatic. He said he has no complaints. He was doing okay.
No medicines taken.
No medications, nothing, sir. No diet followed, no medications taken. His second presentation was 8 months ago in January, when he had history of pedal edema that was gradual in onset and associated with shortness of breath. That is again MMRC grade 2 to grade 3. Again on evaluation, he was found to have renal dysfunction and was told to be leaking protein in the urine and advised for a renal biopsy.
3 years back?
No advice for renal biopsy, sir. Only medical management was given for him and asked to follow up, but he didn't follow up.
Was it seen by a big hospital?
No,
Small hospital?
local hospital, sir.
This
also by local hospital in Nizamabad, sir.
Here you advised for renal biopsy.
Renal biopsy, sir. After the biopsy, he was started on statins, diuretic, and RAS blockade, and was told to visit after 1 month. But after resolution of symptoms, he stopped the medications because of some financial issues. And for the next 7 months, he was doing okay. Now the present complaint, now again from the last 1 month, he's been noticing to develop swelling. That is again insidious in onset, gradually progressive up to the thigh level. It was associated with decreased appetite, weakness, tiredness. He developed reduced urine output 3 days before the presentation to the hospital. And he had history of shortness of breath, that is NYHA grade 4 at presentation. And at the presentation, he was evaluated, and in view of fluid overload and no output, he was initiated on hemodialysis. He has undergone total 3 cycles of hemodialysis from the admission. I have examined him on the 4th day of admission. During these 3 episodes, he denies any history of any hematuria, dysuria, urgency or hesitancy, any flank pain. He denies any history of any abdominal pain, vomiting or distension. He has no history of any blurring of vision or any tingling and numbness. He complains of bilateral knee pain, for which he's been taking painkillers from the last 3 months on and off. He has no history of any fever, weight loss, any blood in the motion, or any alternation of his bowel habits, or any continuous cough with expectoration. He doesn't have any history of any allergy or no history of any intake of native medications. His diet, he is on a mixed diet and he doesn't take any, it has no dietary restrictions. His sleep is normal. Addictions, he consumes toddy, which he stopped 1 month back. The volume he could not quantify. His bowel and bladder habits were disturbed, but he's passing motion regularly. Vaccination history he could not recollect. Family history, there were no similar complaints of any kidney disease in the family. Examination, ma'am?
Continue.
In examination,
Findings only, because
Yes,
of
sir.
short list.
his height was around 164 centimeters. His weight was 70 at admission, now it's 65. Ma'am, we calculated the BMI, it's coming around 24.1. His blood pressure in the left upper limb is 120 by 80, and in the on standing up it is 120 by 80, sir, ma'am. And there was no pallor, there was no icterus, there is no cyanosis, there is no clubbing, there was no lymphadenopathy, there was painless pitting pedal edema up till the ankle level. And the pulse rate, there, it was 82 per minute, regular, rhythmic.
Positive findings.
Positive findings, ma'am. Edema, painless pitting pedal edema up till the ankle. In the CVS examination, there was an ejection systolic murmur, S1, S2 were heard. Respiratory examination, breath sounds were decreased in the infrascapular area and interscapular areas.
Both sides.
Both sides. Para-abdomen was soft. There was no organomegaly, and bowel sounds were present. CNS, there were no other findings, specific findings.
Do you have urine analysis results?
No, I don't have.
Urine shows 4+ proteinuria and 10 to 15 RBCs.
Yes, ma'am.
Now what is your diagnosis?
It is a nephrotic syndrome, ma'am.
Where is the nephritic syndrome here?
Because one thing is he's having RBCs, ma'am. Then he's having reduced urine output at presentation now. There's reduced output, he's having hypertension.
I don't think you can say nephritic syndrome here. 3 years history of edema, on and off edema, proteinuria and hypertension, and 10 to 15 RBCs on urine analysis.
And he's undergone biopsy also, no?
Yes, sir.
Biopsy did not help with any steroids, he was put on some statins and ACE inhibitor and all.
Yes, yes, sir.
What do you think? Instead for all the biopsy done, you know the treatment?
It would most probably be a nephrotic syndrome, sir, because he was
nephrotic syndrome in a 60-year-old man, isn't it?
Yes, sir. Yes, ma'am.
With a few microhematuria.
Microhematuria.
With microhematuria, you can't say this is nephritic syndrome.
Okay, ma'am.
And clinical presentation also should fit into the nephritic picture.
Yes, ma'am.
And what do you think the cause of that dyspnea on exertion? Is it common with a nephrotic syndrome?
Generally, if nephrotic syndrome has gone into fluid overload, ma'am, it can cause.
Where is the fluid accumulated in
the
nephrotic?
third space.
Will it produce fluid overload?
Generally, it should
What
not.
will be the intravascular volume status?
It will be reduced, ma'am.
So how can they develop orthopnea and exertional dyspnea?
Yes, ma'am. And
So what can be the reason for that exertional dyspnea?
could even be a cardiovascular complication, ma'am.
Unassociated.
Associated cardiovascular complication, very common with nephrotic syndrome. They have increased association of cardiovascular complications, one. And pulmonary thromboembolism is also common with nephrotic syndrome that can present with.
All these present with an acute presentation, isn't it?
Yes,
not
acute
exertional dyspnea.
Acute worsening. Yes, ma'am.
Can that hypertension be responsible for exertional dyspnea?
Yes, ma'am. Uncontrolled hypertension can also lead to pulmonary edema.
Okay. Now, if this is a nephrotic syndrome, what are the other negative history you want to elaborate in a 68-year-old man?
The other history, I would like to find out if any systemic involvement is there, ma'am. Systemic involvement in the form of any cardiac involvement or any nerve involvement, ma'am.
That is for the complications of nephrotic. What Madam is trying to ask, what is the etiological basis for this nephrotic syndrome?
Etiologically, I would want to know.
According to you, what is the likely cause of nephrotic syndrome here?
In this patient, 68 years old.
It could be, first thing would be membranous because of the age group, ma'am.
Other possible causes?
Other possible causes could be minimal change disease, FSGS, and amyloidosis.
Amyloidosis. Anything else? Third possibility?
FSGS, ma'am.
Okay. Something else? In elderly?
68-year-old man.
68-year-old man.
MCD, minimal change disease.
In this 68-year-old man. Can this be a monoclonal
Yeah,
gammopathy?
it can be a monoclonal gammopathy.
Light chain
also.
deposition.
Light chain deposition disease also
Isn't
is
it?
problem. So lower back
So
pain.
with these in mind, what are the negative histories to be discussed in this case?
To rule out membranous, most common cause of membranous in a 60 years is malignancy, ma'am.
That is not the most common. But what is the most common cause of membranous nephropathy in a 60-year-old man? It is primary membranous,
Primary.
isn't it? What percentage is secondary in membranous nephropathy overall?
20.
20 to 30%. Of these 30%, what are the causes?
Prostate cancer, lung cancer, and pulmonary cancer.
Solid tumors.
Solid tumors.
Commonest site being
Colon,
lung, breast, colon, and prostate. Okay, so discuss the symptoms of malignancy in these areas as negative. Then, what is the second group of diseases associated with membranous?
Certain
Chronic infections and inflammations. Isn't it? So you have to discuss any chronic inflammatory disease present or not. Then, third group of causes of membranous?
Drugs. NSAIDs, penicillin.
Prototype drug is it NSAID? Prototype drug which produce membranous? Penicillamine. Penicillamine is the prototype drug. All heavy metals can produce membranous nephropathy, isn't it? Okay.
Yes,
Then to rule out monoclonal gammopathy, you have to discuss other
back pain,
constitutional symptoms, bone pain, back pain, etc., etc. So this is how you have to put your negative history here.
Yes, ma'am.
Okay. Sir.
So how would you proceed further? A biopsy has already been done.
Yes, it has been done, and the second visit, that was in January, sir.
In January it has already been done. But we don't know the findings. And okay, so supposing it does turn out to be a MGN, a membranous nephropathy, what other investigations would you do?
I would like to do a PLA2R, sir. PLA2R to see for primary membranous, and I would like to do because of his age, I would like to do a screening for malignancy, like for prostate specific
Yeah, that
antigen.
you discussed already. So PLA2R you look for where?
Sir, in the blood and even in the biopsy, sir.
In the biopsy also.
Yes, sir.
Which is more specific or consistent with active disease?
In the biopsy, PLA2R.
Antigen and EHC4 PL2R
Right.
antigen.
And if you do an immunofluorescence on that biopsy, what would you find?
We would see deposition, sir. Subendo.
Subendo.
Subepi.
Exam going PG.
The location of the deposits is seen on EM.
Yeah.
IF you don't see the location of the deposit, right? IF you see what are you looking for on IF?
IgG deposits.
Yeah.
IgG4 in case of primary membranous.
Yes, IgG4. Yes, that's the
You can say just capillary wall IgG.
capillary wall IgG, and specifically it will be, if you look for subtypes, it will be IgG4. Yes.
And in the electron microscopy, location?
Capillary.
No, it's
Still
again
capillary wall?
subepithelial.
Subepithelial.
There it is
Subepithelial.
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 You
Any
heard-
special stain on the LM?
Yeah, I was just coming to
Silver staining, we can see the spikes, ma'am, in
Yeah.
case of membranous.
That's in what stage of membranous?
What are the 4 stages of membranous nephropathy?
Four stages. First is when there's normal light microscopy with only immunofluorescence will be there, ma'am. Second is when there are spikes that can be seen in silver staining.
What is the spike due to?
There is a subepithelial deposition, and there's formation of the glomerular basement membrane on top of it, like a second membrane that gives the spike appearance in silver staining, ma'am.
Does the growth of
New-
GBM in between
In
the
between the
deposits,
deposits, you know,
between
which
the
is seen as
spike.
spikes. And stage 3 will be incorporation of these,
Layer.
Yeah, it will
and stage 4 will
encircle
be resorption of the deposits. What is the normal GBM thickness?
It's between 300 to 350, ma'am.
Okay, when will you say this is a thickened GBM? LM may pick up a thickening, stiff capillary wall. That is the usual description by the pathologist, isn't it?
It's around 395 in males and 430 in females, ma'am. The thickness.
Reverse it.
Reverse.
Females
Males
always
430
less.
and 390 females.
And what is a thin basement membrane?
Around, it's in case of Alport, sir, the thickness will be less than
Need not be Alport. How can it be in Alport? You are asked what is definition of a thin basement membrane.
250, around 250 nanometers.
Less than
250 and
250.
less.
Less than-
Yeah.
Less than 250.
Less than 250.
How do you compare a light microscope, thick and a thin GVM? Are you not able to measure the calipers?
What you will compare?
What do you compare? Reference point. You compare with me, you are fatter than me. You have a comparison like me or somebody else.
Yes,
What
sir.
do you compare? You have to reference, no? With that, by seeing that, okay, it is thinner than that, it is thicker than that. So what else, other basement membranes are there in the biopsy, which will guide you?
Tubular basement membrane.
How will you differentiate a primary and a secondary membranous by histopathology?
Based on the immunofluorescence IgG, ma'am. IgG.
Light microscopy. So classically, normocellular tuft in primary, any
And
mesangial
proliferation, second.
mesangial or endothelial or extracapillary proliferation, if present, is consistent with a secondary membranous. Immunofluorescence wise,
It will be IgG4 predominant in case of primary membranous.
immunofluorescence site of deposition,
Immunofluorescence site will, in case of primary, it will be along the capillary wall, but in case of secondary, it will be in the mesangium as well, ma'am.
okay, associated subendothelial or mesangial deposits if present. Then type of immunoglobulin,
They predominantly in secondary, it will be IgG1 or to IgG3, ma'am, but IgG4 is in
it is
primary.
IgG4 in primary membranous, isn't it? And you can also stain for PLA2 or
Or
antigen
antigen.
by IHC. These are the four differences in primary, secondary.
So how will you manage this patient?
Sir, in case of membranous, we first need to start them on non-immunosuppressive therapy, that is with diet management, that is salt and water restriction, RAS blockade, and if they're having hyperlipidemia or they're having risk factors for coronary vascular disease, we start them on statins. And we follow them up for 6 months, sir. We see if the proteinuria is decreasing, because most of the times, 1/3 of the cases, the membranous will spontaneously resolve, sir. So if it's resolving, then we can continue the conservative management.
Any indication for immediate initiation of immunosuppressive drugs?
If
You
the
will not wait for 6 months here.
if there is in the presence of if there is a presence of renal there's rapid worsening of the renal function, there is massive
What
proteinuria
are the
and
points to
complications.
say that this is a very high risk patient?
Proteinuria more than 8 grams, ma'am, creatinine more than 1.5, and if they're having any thromboembolic events, then we can say this is a very high risk group and they require
Life-threatening nephrotic
syndrome.
state. Life-threatening nephrotic state.
But any role of PLAR2, initially this entire MPG, or the membranous nephropathy treatment was based on only proteinuria. Then later on the PLAR2 also came. Any role of PLAR2 in this?
yes,
Or PLAR2, does it indicate anything?
yes, sir.
Is it an indication for starting early immunosuppression or you still go with proteinuria?
Sir, it is for monitoring the
No,
therapy.
initiation of treatment, role of antibody level of anti-PLA2 or antibody.
Yes, more than 50, I think we need to initiate the
Is it more than 50? More than 150, isn't it? For high risk. More than 150. So what is the other indications for monitoring your anti-PLA2 or antibody titers?
If the patient has gone into recovery, ma'am, he's
One
recovered.
is diagnostic.
Diagnostic and
100% specific for diagnosis. 1, 2.
for relapse, ma'am.
Initiation of treatment.
Treatment.
More than 150. You have to check that value of 150 to initiate on treatment. Then
Response to therapy.
at the end of 6 months of conservative treatment, if you do a repeat anti-PLA2 or antibody, what is your
If it's a decreasing trend, it's falling down, then the treatment is working, ma'am. We don't have to go upgrade our to start immunosuppression.
Okay, that is the third stage. Any other indication or use of monitoring anti-PLA2 or antibody level?
In case of relapse, ma'am.
At the end
they
of
keep
6
that-
months of modified Ponticelli regimen, you are repeating anti-PLA2 or antibody. What is its use? Patient has still persistent nephrotic range proteinuria. Anti-PLA2R level is undetectable. What is your plan of action?
But to
Will you intensify immunosuppression or continue immunosuppression, or you will wait and watch?
we'll wait and watch, ma'am.
You can comfortably wait and watch for another 6 months for a delayed effect of your Ponticelli regimen, isn't it? Then, in the post-transplant, pre-transplant,
If there are higher levels of PLA2R, then there's higher chances of recurrence post-transplant.
so it should be negative at transplant.
Transplant.
Post-transplant nephrotic proteinuria, how it is beneficial?
Post-transplant nephrotic protein.
Patient develops again massive proteinuria after transplant.
Again, if the PLA2R levels are elevated, that means there's a recurrence of the
It is the
disease.
recurrence. So, to differentiate between recurrence of the disease or a de novo membranous. These are the 5 indications for or usefulness of monitoring PLA2R antibody titers.
So can you just give us a brief idea of the various trials that have been done in membranous nephropathy?
One of them is the MENTA trial, sir.
What was the first one? First tell us that. It still has validity today.
Ponticelli.
Yeah.
We give alternatively 1/3 and 5th month we give steroids, sir. That is pulse steroid for the first 3 days and followed by 0.5 mg of
Okay, fine.
and alternatively with cyclophosphamide or chlorambucil.
Yes, 6 months. Okay.
6 months.
Other than, besides that, beyond that, after that, what
Response
happens?
rate to Ponticelli? What percentage of them will go remission with Ponticelli regimen?
Around 60.
Yeah, around
60,
60-65%. Yes. Okay.
Then,
Then CNI versus versus the Ponticelli. Cyclosporin versus cyclophosphamide.
Regimens you told, sir asked what regimen. One is you told Ponticelli.
Names.
Any other? You said cyclophosphamide. This is also cyclophosphamide based on it. CNI you told. Next.
Then rituximab based regimens.
Hmm.
And
Gemritux was the first one, the rituximab based regimen. And then after that,
then after that
Mentor,
Mentor,
Starman came later, and finally RI Cyclo. So you should remember all these. All these are relatively recent. The only older one is the Ponticelli
Ponticelli.
one. The others are all recent. And what is the final conclusion after all these studies?
Which is better for induction
Which is-
and maintenance.
Which is probably the best regimen, on the basis of whatever evidence we have.
Ponticelli regime is still the best regimen.
So if you have severe disease,
Yes.
that may be the best regimen.
Yeah.
So this is one disease where, such an old regimen, which came in the 90s,
Yes, sir.
is still
Valid.
So why do you think that patient has progressed? He's a membranous nephropathy, no? And suddenly he doesn't do renal failure requiring
Because of
dialysis.
he's not taking their medications properly, he's not filing dietary restrictions.
Still, how
And
does
hypertension,
membranous
sir.
nephropathy will progress. Membranous nephropathy. how-
Generally,
natural progression.
the progression to CKD is very late, sir.
This entire history is only 3 years.
3 years. Yes,
And,
sir.
January itself he undergone a biopsy. There may be milder disease. That's why they put on statin and ARBs.
Yes, sir.
Nothing much further. Within 8 months, he progressed to ESRD. Or an acute event is there.
Maybe an acute event is there, sir, that is causing him to be
What are the
dialysis
causes
dependent.
of acute kidney injury and nephrotic syndrome?
In this patient,
Uh,
68 years of age.
They can be divided into pre-renal, renal, and post-renal. Pre-renal could be volume depletion and certain nephrotoxic drugs that are used. Then even pre-renal could even be because of secondary to renal vein thrombosis. renal could be secondary to acute tubular necrosis or sepsis causing acute tubular necrosis, and post-renal
Post-renal don't fit in here. This patient did receive NSAIDs you
And,
mentioned for knee
papillary
pain he
necrosis.
was taking.
Yes, ma'am.
For
they,
osteoarthritis.
yeah, so they may have contributed, we don't know really.
Older kidney nephrotic syndrome and NSAID abuse.
Do you want to give him aspirin prophylaxis or anticoagulants?
When we calculate, generally patients of nephrotic syndrome are having an increased risk of cardiovascular complications. If we can do an ASVD score, ma'am, and if it is high, then we can start him on aspirin. And if the albumin is lower than 2.5, then we can start him on anticoagulation.
Would you give everybody anticoagulation if the albumin is below 2.5? That is the difficult question, isn't it?
Who are not responding to treatment and who continue to have nephrotic syndrome, we prefer to give them anticoagulation.
No, if there is a past episode of thromboembolism of any kind, then there is no question. So then you would give that. But in the absence of any past episode, there's still controversy. Yeah. This is not a area where you can confidently say that they are indicated.
Why they have more chance of thromboembolic disease?
Because when in the proteinuria they even lose proteins such as protein C, protein S, and there is increase in fibrinogen, ma'am. So they are having increased predisposition for thrombosis, arterial or venous.
So loss of anticoagulants in, like protein C and antifibrin 3.
Then there is increase in levels of fibrinogen, ma'am.
Okay, increased fibrinogen.
And because
What happens to other procoagulant factors?
they increase, ma'am.
Why?
Because the albumin is reduced, the liver starts synthesizing proteins and they are
So
synthesized.
liver synthesizes more procoagulant proteins than other reasons.
Other reasons are immobility, ma'am, and
Immobility.
hemoconcentration.
Hemoconcentration, agreed. Anything else? Any platelet abnormalities? Aggregability, adhesiveness of platelets?
Will increase in case of
Why?
not very sure.
Then anything in relation to the clot that is formed? Any difference in clot in
It's
a
fibrin-
normal population versus
It's a
nephrotic syndrome?
fibrin-rich clot, ma'am, compared to a platelet-rich clot in normal population.
There is some difference in the pore size of the clots, etc. It's not easily degradable there are some reasons for that also. So because of these reasons, they are prone for more of thromboembolic episodes.
Can you get arterial thrombosis also in nephrotics?
It's very rare, but it could be a possibility, sir.
Yeah, it has been reported, particularly in childhood, more in children than in adults, but can happen.
Requires a lifelong anticoagulation since.
Yes, yes. So that can be very serious. Which are the kidney diseases in general in which progression is relatively slow, very slow? This is one example, right? Which others?
IgA also, if they're well managed,
Yes,
their progression
can be.
Then if there is a secondary FSGS also, the progression will be slow, sir, because the protein.
Okay, FSGS, yes, can be slow.
Then
Yeah, all of you need to remember, when we're talking of rate of progression, the rate of progression, even with the same disease, can be different in two patients, very different, right? So one patient with FSGS may progress rapidly, have a malignant course, and one patient may progress over 15 years, right? So remember that. But yes, many patients with FSGS, very slow progression, particularly those with non-nephrotic proteinuria, right? So as you said, IgA is fine, FSGS, MGN we've already talked about. Any other?
Any tubulointerstitial disease?
Tubulointerstitial disease, yes,
also.
generally are more slowly progressive, yes. Any other disease that we have already discussed today?
ADPKD. is also
ADPKD,
slowly
yes.
progressive.
Isn't it very slowly progressive?
Yes, sir.
So these are some important examples of very slowly progressive disease.
What are the newer antigens identified in the morning?
Thrombospondin 7A, ma'am. Neural.
Which associated with what?
It is associated with
Malignancy associated.
Then NEL1, ma'am. The other ones are exhaustocin, semicolon
1 and 2 associated
1 and
with
2 with
lupus.
lupus,
Lupus.
yes.
then
Then we have semaporin 3B, that is associated with childhood membranous.
pediatric nephrotic.
And
Some of them well studied, some of them are research.